Welcome, everybody. This is Alice Bonner. I chair the Moving Forward Nursing Home Quality Coalition, along with my colleagues, Emily Willard and Jennifer Baker. And we're very glad to be here today with a panel of guest speakers to talk about a topic that seems to be of significant importance to many of you. We had a big sign up of people today. We're going to be talking about, framing how Medicaid matters in the relationship between payment structures and nursing home quality. So, our goal today is to raise some additional awareness of why Medicaid matters and shed some light on the, relationship between payment and payment to cost ratios and nursing home quality. So you're going to hear a lot of that conversation today. There's a variety of reasons why, but there's little evidence on how, the nursing home level on how Medicaid payments align with the actual cost of delivering quality care. So you're going to hear today about some of the recent research from UMass Boston and Miami University and how they're looking at what we do have available to talk more about this issue. So again, you're going to hear about a newly developed, nursing home specific database and the researchers and how they've done the study. This is really critical, as many of you on this call, but not everybody may know, about 60 or 70% of the 1.2 million people who live in almost 15,000 nursing homes in the United States rely on Medicaid for their payments. So that's how they fund and structure care. So, the research findings we're going to hear about and talk about today are going to give some insights into Medicaid payment influences. So you're going to hear more about that. I will say that what we've done, because we have these presenters who have a lot of content to share, we're going to have people on mute during the presentation. And then at the end, we're going to try to leave about 10 minutes for discussion. So then we'll ask you to unmute yourself by raising your hand, and then Emily or Jennifer or I can let you speak to or ask a question. So with that, I'm going to turn it over to our panel. I'm going to introduce our four speakers very quickly, and then we'll get to the meat of the program. So we have with us today Dr. Edward Miller. He's a professor and chair of the Department of Gerontology and a fellow in the Gerontology Institute at the Donna M. and Robert J. Manning College of Nursing and Health Sciences at the University of Massachusetts, Boston. And his work examines how policies, programs, and practices shape the lives of older adults who rely on long-term care services and supports. In addition, we have Dr. John Bowblis, who's a professor of economics at the Farmer School of Business and a research fellow in the Scripps Gerontology Center. And he received his doctorate degree from Rutgers University before joining the faculty at Miami University. And he does a lot of scholarly writing on how to better understand how markets develop, how competitors interact with one another, and about public policy. We also have Liz Simpson, who's a doctoral candidate in the gerontology department at the University of Massachusetts, Boston. Her research interests are Medicaid nursing home payment policy, coordinated care for older adults in communities, and housing and supportive services. And finally, Dr. Marc Cohen, who's going to lead us off today, who's a professor of gerontology at UMass Boston, where he serves as co-director of the Leading Age LTSS Center and as innovation and as a research director at the Center for Community Engagement in Health Innovation at Community Catalyst. That's a mouthful. Before joining UMass, he was Chief Research and Development Officer and former president and co-founder of Life Plans, doing research with a risk management company. So I have read a very short version of their bios. These are extremely accomplished, wonderful colleagues. We're so glad to have them. And with that, Marc, I think we're going to kick it over to you to start us off today.
Great. Thanks so much, Alice. You forgot to mention the most important thing. I was part of the Moving Forward Coalition.
Yes, you were.
That is my actual claim to fame. So let's go to the next slide. We have a lot of material we're going to go through today. Here we go. We're going to briefly discuss three studies. The first one is to look at Medicaid payment rates and their relationship to the cost of providing care to Medicaid residents. The second is to uncover the extent to which there's a relationship between the level of payments and five-star quality ratings that most, if not all of you, are aware of. And the third is to look at the relationship between Medicaid payment rates, and examine whether they undermine or there's relationship with staffing. Next slide. These research projects were funded by the Donahue Foundation and the Department of Health and Human Services. And the content of this talk is solely our responsibility and should not be attributed to either of our wonderful funders. So with that, I'm going to turn it over. I believe, Eddie, you're kicking us off?
I am not.
You are
John
not.
Bowblis is.
John, go ahead, John.
Great. So, for all of this to understand sort of like what's the relationship with Medicaid payments in nursing homes and in terms of quality, we first need to be able to know what Medicaid payments are and what's the actual cost of caring for those individuals. And so that's the first study that we did. If you want to go to the next slide. So obviously the main point of our talk is to discuss, how Medicaid payments in nursing homes are related to quality, but the starting point of that is actually determining what Medicaid payment rates are, as well as understanding, how the cost associated with that. And so it's important to understand that each Medicaid program is different. There are really 50 different states, and they have 50 different ways of calculating Medicaid payment rates. However, those rate methodologies are at least regulated at the federal level, and they don't have to cover the full cost of care. In particular, there's a lot of different variation and methods that different states use. For example, some states use the actual Medicaid cost reports to determine what the actual cost of providing care is. Other states use what's called a price system, where they sort of estimate what those prices or costs would be. And then there's also differences across states in how often they update those Medicaid payment rates. If we go to the next slide, so because of that, there's not a lot of research that looks at the relationship between these Medicaid rates and the actual cost of coverage or cost of care to the nursing home. Collecting that data is actually relatively limited. And so what we tried to do in this study was to actually go out and collect those Medicaid payment rates and look at the underlying costs. So if we can go to the next slide, I don't know if somebody's moving that forward. Next one, the purpose, sorry. So what we're going to do in this particular thing that's a little bit different than other studies is that some studies have looked at Medicaid payment rates at sort of the entire state level, sort of saying, what is the average payment rate for the typical person on Medicaid? What we wound up doing is trying to understand what was the specific rate that was paid to each individual nursing home and what was the actual cost of providing services in those nursing homes. So the next slide that we have actually highlights what our three research questions are. So next slide, please. The first thing that we wanted to do was understand what was the average cost of caring for somebody who's on Medicaid. The second thing we wanted to know was what was the actual average payment rate that each nursing home sort of received for those patients. And then the last thing was to compare what those payment rates are to the actual underlying costs. So if we just go 2 slides ahead, we'll talk a little bit about the data. The way that we did this is we first went out and had to go out and collect the actual Medicaid payment rates for each nursing home. We wound up doing this for 2019, and what we obtained was what we called the statutory rate. This is essentially the rate that the typical person on Medicaid would have been received, or I should say the facility would receive for the typical person. There are some state, add-ons for private rooms, for example, in Ohio, where somebody might be on a ventilator unit and things along those lines. We're not accounting for that. In certain states, we actually had to take sort of the Medicaid cost reports to find the average reimbursement. We were able to collect data for 44 states. What we then did is we took the Medicare cost reports, which is the only financial information on a national basis, for all nursing homes across the United States, to try to match those Medicaid payment rates to what's the actual cost of providing care to somebody on Medicaid. If you actually look at the ASPE study, we go into detail on how we calculated that, but the objective was to sort of look at take the cost of caring for the average person, and then that we know that people on Medicare tend to cost more because they're getting post-acute care, more intensive services. They're also getting additional services somebody who's a long stayer on Medicaid may not receive. And then what we're doing is trying to back that out to what the Medicaid payment rate would be. The key point is that that Medicaid payment rate is an estimate, and it reflects the actual operations of the nursing home. So, for example, if a nursing home is understaffed, we're looking at what that actual cost is. If a nursing home is overstaffed, we're looking at what that actual cost is. So we're not trying to sit here and say, what is the optimal staffing level? We're just sort of saying, based on 2019, how did nursing homes behave? And based on that behavior, what would their cost of providing somebody on Medicaid be? So if we go to the next slide, we can talk about how we sort of built that data set. So we know we started with what's called freestanding nursing homes. These are nursing homes that are not part of a hospital. There was about 14,000 of those in the United States in 2019. What we then did is we said, if we looked at those 44 states, we were able to, the maximum number of nursing homes we can look at was 13,000. What we then said is we're going to look at the Medicare cost reports, and we're going to make sure those Medicare cost reports meet some type of reliability. The first thing that we did is we looked at what we call full year Medicare cost reports. These are cost reports that have a 365-day period. The reason why we want to look at this is because if a nursing home went under an ownership change, that can increase cost, it can change behavior. That left us with about 12,000. We then had to be able to match that particular nursing home to their specific Medicaid payment rate. That left us with 11,000. And then we do know that some nursing homes will report additional cost if they have, say, an assisted living or another type of residential unit attached to that. And so what we wound up doing is excluding nursing homes, what we called non-nursing home beds, or these residential care units. And that left us with about 10,000. And then, of course, there are some type of cost outliers. So we looked at cost outliers by basically eliminating those that were really, really low and really, really high. And that left us with a sample of about 9,500 nursing homes, representing about 72% of all potential nursing homes we could have looked at. The next slide contains what our analysis is. What we did is we looked at what was the Medicaid payment rate. We looked at the estimated Medicaid cost, and then we looked at something that was called the payment to cost ratio. Essentially, that's taking what was the per diem cost, or say payment, and dividing it by the per diem cost. And so if that number was 1, that basically reflects that that Medicaid was paying exactly what the cost of caring for that person was. If that number is less than 1, then what happens is that means that that nursing home represents it's actually getting paid less than what the actual cost of care is. If the number is greater than 1, Medicaid is actually above the estimated cost. We did that for just the Medicaid payment, and we did it for something that we called the all-payer level, which represents Medicare, Medicaid, and any source of revenue. So if we go to the next slide, we're going to go through our findings. And so what our findings first are is what was sort of the average and median all-payer and Medicaid per diems. If you go all the way to the left, we have the all-payer payment rate. So the average nursing home received $284 per day. The median was a little bit less at $265. If we go to the cost for the all-payer, their cost on average was $287. The median cost was $207. If we look at the Medicaid payment rates, those numbers are just slightly under $200, but the cost of caring for those individuals, the average was $253 in the nation, and $240 was the median cost. The next slide, what we have is our payment to cost ratios. Now, even though these averages are there, what happens is you need to look at what the actual cost and payment was for each nursing home. What we're basically showing here is that when we look at all payers, Medicare, Medicaid, the average in the median nursing home is basically breaking even. They're making about as much money as it's costing them to operate. However, if we look at the Medicaid side of the business, the nursing homes are getting paid about 82 to 83 cents on the dollar. So that means for the average nursing home across the United States, they're actually losing money on Medicaid. I will let you know that there are some states where that's, the numbers look better than others. It just depends on the specific state. So on the next slide, what we have is the actual distribution, which gives you an idea of what does the Medicaid, how bad is it for nursing homes in terms of this gap between the payment and costs? And you'll see that the biggest bar is right in the center, where 31% of the nursing homes that we looked at were getting paid between 80 to 90 cents on the dollar. And then we had about 21% getting between 90 to the full 90 cents on a dollar to the full cost. Another 23% were getting 70 cents to 80 cents on the dollar. About 8% of nursing homes were actually able to make a profit under Medicaid. And you can see that there are some nursing homes, about 7%, that were losing 60 cents or basically getting reimbursed 60 cents on the dollar. So there is a lot of variation here. A lot of that is related to the staffing issues that we'll talk about next. Just to sort of give the overall conclusions here in terms of what we basically found. If we just go 2 slides forward. Basically, Medicaid is covering about 82 cents on the dollar. The vast majority of nursing homes in our sample, 92%, were basically being paid by Medicaid below the cost. 40% were getting paid under 80%, about 8% were making a profit. And so what's happening here is that there is this cross-subsidization going on. Nursing homes are making profits through Medicare, they're making profits through private pay, and they're using that to subsidize losses on Medicaid. If we look at other facilities, there are some facilities like nonprofits who may be making profits from running an assisted living or an independent living and using some of those profits to subsidize the cost of care in the nursing home. Just to highlight some of the limitations on the next slide, we do want to point out that this is based off experience from 2019. Obviously, the pandemic has changed this a lot. I can tell you that some states have increased their Medicaid payment rates significantly. Other states have not matched the cost changes. The other thing it's important to understand is that we're looking at the statutory rate, which is basically what the law says. It may not capture all payments. So, for example, some payments may have to come from residents. We aren't including that, or it should be included in that. But if there are supplemental payments that are often made, sometimes to government-owned nursing homes, or there might be supplemental payments for private rooms or ventilator units, those are not included in this. And then the next limitation slide that we have, basically, it's important to understand that we're trying to make certain adjustments to best match what Medicaid payment rates are. That those estimates will be with some error, and that we did try to reduce the sample to those nursing homes that don't have substantially different cost structures. So if you are part of a combined assisted living where that cost was embedded in there, those nursing homes can be different. And it's important to understand that, we're looking at what current care practices are. We're not taking a stand whether nursing staff levels should be higher or they should be lower or things along those lines. So with that, we'll just go 2 slides ahead and talk about what the next issue is, which is taking these Medicaid payment rates and these payment to cost ratios. We're interested in understanding how Medicaid payments affect the quality of care that's going to residents. It's important to understand that there's been not many studies on this in the last 20 years. Most of the studies are 15 years or older. They look at state level data, meaning they look at what is the Medicaid payment rate for the entire state on average, and that's about it. So by being able to have facility specific level data beyond a single state, we're able to look at a more refined view about this relationship in sort of a modern context, especially given the fact that the quality information that's available to consumers today is a lot different than the available information that there was 20 years ago. And so with that, I believe I'm supposed to turn it over to Liz.
Actually, it's Eddie.
Eddie, sorry.
That's okay. Liz will go next. Going to try and expedite this a little bit. We'll do what we can so we have time for some discussion at the end. So this first study, following sort of our baseline study, looked at the relationship between Medicaid payment adequacy and the 5-star quality ratings. Our purpose was to, the association, to what extent are Medicaid payment rates and to what extent are the Medicaid payment to cost ratio associated with the nursing home quality, at least as measured by the 5-star system. Skip to the data slide. Just want to say we used a wide variety of data sources and the data that John just described, as well as from the 5-star, payroll-based journal, Medicare cost reports, minimum data set, and Casper system. Next slide. Same sample that John talked about, except we excluded nursing homes that didn't have a star rating, and there were a few that didn't have MDS assessments. So again, about a sample of about 9,500 facilities, but a few less than the original study. Our explanatory variables were the Medicaid payment rates. We categorized these into 7 groups, and we did the same with the Medicaid payment to cost ratio. We categorized these into 7 groups. Next slide. Our dependent variables reflected the 5-star system, where, of course, 1 star is much below average quality, and 5 stars is much above average quality. We looked at the specific domains, inspections, quality measures, and staffing, as well as the overall measure, which is a composite of the 3 individual measures. Star ratings were measured from the last month of each nursing home's fiscal year, in which the Medicaid payment and cost data were collected. And we actually measured this with a binary variable. We basically comparing facilities with a 4 or 5-star rating compared to those with 1, 2, or 3 stars. Next slide. Way ahead of me. All right, covariates. We conducted regression analyses and we controlled for other factors that might be associated with 5-star performance. Next slide. You'll see descriptive statistics. We looked at bivariate associations, that is simple relationships between the payment outcomes and the star rating outcomes. And then we conducted some multivariate linear regression, that is looking at these relationships, controlling for other factors that might influence the 5-star rating. For the payment analyses, we're able to look at all the 4-star ratings that we were looking at. So inspections, the quality indicators, staffing, and the overall. But for the payment to cost ratio, we looked at all those but the staffing rating. And the reason is that nurse staffing is really the largest expenditure, nursing home expenditure. And so they're what might be called endogeneity. That is, basically the dependent variable being embedded within the independent variable, which is the costs, the staffing costs that we're looking at. So again, we adjusted for all the covariates, and that's to better isolate and be confident that the relationship, if we find one, is a real relationship and not because we left out other potential explanations for the 5 stars. All right, so skipping ahead to Medicaid per diem payment, most nursing homes, about 80%, had average per diem payments under $225 per day. Next slide. About 1/5 had Medicaid payment to cost ratios below 0.7, meaning that Medicaid payments covered less than 70% of Medicaid costs, and less than 10% of nursing homes had Medicaid payments that exceeded costs. The percentage of nursing homes rated 4 or 5 stars ranged, 47%, in the overall rating, about 32% for the health inspection rating, and 36% for the staffing rating. And actually the quality rating, most nursing homes, about 2/3, were rated 4 or 5 stars on that measure. Next slide. All right, so what do we see? Here we see the percentage of nursing homes with 4 or 5-star ratings by Medicaid payment. So the results indicate that higher payment rates were generally associated with higher percentages of nursing homes being rated 4 or 5 stars across all 4-star ratings. So for example, less than 45% of nursing homes at each of the 2 lowest Medicaid payment levels, that is $0 to $175, $176 to $200, had high overall star ratings. Whereas you can see, and this is the bracketed, nursing homes with payment levels above $251, each of these 3 categories, about 2/3 actually were rated 4 or 5 stars. Okay, next slide. By contrast, higher Medicaid payment to cost ratios were generally not associated with higher star ratings before we adjusted for other factors. So indeed, nursing homes with the lowest Medicaid payment to cost ratios, that is 0 to 6, that's the bracket you can see there, a high percentage of nursing homes with low Medicaid payment to cost ratios were more likely to be rated 4 or 5 stars, and that percentage tended to decline as payment to cost ratios increased. Okay, and we'll talk more about that in a second. Now, looking at the regression results, they indicate that compared to Medicaid payment rate of $0 to $175, that is all these, all the numbers you see are in reference to that low Medicaid payment rate level, $0 to $175. Nursing homes generally had higher probability of being rated 4 or 5 stars for the overall, health inspection, and staffing ratings as Medicaid payment rates increased after we adjusted for covariates. So for example, increasing per diem payment rate from less than $175 to $176 to $200 was associated with a 4.9 percentage point increase in having an overall star rating of 4 or 5 stars. Now, when the Medicaid per diem rate rose to over $300, the increase was 39.7 percentage points. Now, we didn't see any association that was really evident between the payment rate and quality measure rating. All right, next slide. Now, turning to the Medicaid payment to cost ratio, the regression results indicate that for the overall and the health inspection ratings, there was no statistical difference in star ratings for Medicaid payment to cost ratios ranging from 0 to about 0.9 after adjusting for covariates. On the overall rating, however, nursing homes with Medicaid payment to cost ratios above 0.9 had a 9.8 to 13.7% higher probability of being rated 4 or 5 stars compared to nursing homes with payment to cost ratios of 0 to 0.6. Similarly, on the health inspection rating, nursing homes with Medicaid payment to cost ratios from 0.9 to 1.1 had a 6.6 to 7.9% higher probability of being rated 4 or 5 stars compared to nursing homes with payment to cost ratios of 0 to 0.6. And there was no real meaningful pattern, again, with respect to the quality measure. So I'm going to interpret some of this in a little more plain language. So move ahead a couple slides, please. Well, all right. So even after accounting for facility and resident characteristics, higher Medicaid payment rates are associated with better overall, health inspection, and staffing star ratings. The association with the staffing star ratings suggests that, facilities may be better able to direct greater resources towards compensation, training, and other supports needed to recruit and retain direct care staff. The association with health inspection ratings suggests the capacity to implement the quality assurance and improvement mechanisms required to further compliance with federal quality and safety standards upon which the deficiency citations are based. Collectively, these additional investments in more qualified staff, enhanced training, and quality improvement initiatives translate into higher overall star ratings. Next slide. Now, when looking at the Medicaid payment to cost ratio, our unadjusted findings suggest that nursing homes with lower Medicaid payment to cost ratios have higher star ratings. Now, this might seem counterintuitive, as nursing homes with lower Medicaid payment to cost ratios are losing more money per Medicaid resident day and should have fewer financial resources. However, previous research indicates that these nursing homes offset their losses sustained by caring for Medicaid residents by relying more heavily on higher paying revenue streams from Medicare post-acute residents and private pay long-stay residents. Effectively, other payers are cross-subsidizing care that is associated with caring for Medicaid residents. Thus, through cross-subsidization, nursing homes with lower Medicaid payment to cost ratios may be less constrained in spending on resident care, thereby enabling the investments in staffing, quality improvement, and amenities needed to provide quality care, as evidenced by the higher star ratings. Now, this seems to be confirmed by the study's regression findings, which account for cross-subsidization because we include measures of payer mix among our controls. And here we found that nursing homes with Medicaid payment to cost ratios above 0.9 have higher overall and inspection ratings. In other words, after controlling for other revenue sources and holding them constant, closer approximation between Medicaid payment and costs matters for star rating performance. Move ahead one. There was an association with quality measure ratings. There are a range of possibilities. Medicaid payment measures, we don't really know for sure, but, nursing home staff level, basically Medicaid may impact staffing levels. And one staffing level, they staff to a certain level, and resident clinical characteristics are accounted for, it may not have an incremental impact on the quality measures. There was a high percentage of nursing homes that actually did very well on the quality measure, 68%. So there may have been a lack of variation there. The quality measures as constructed by CMS may not be sensitive or as sensitive indicator of quality as some of the other measures that are used. So same study limitations as before. We weren't able to look at the relationship between Medicaid payment to cost ratio and staffing because of this endogeneity issue. And of course, the star ratings, they don't capture quality fully. And you need to look at other measures of quality to further explore these relationships. So let's skip now to study 3. And Liz will talk about the relationship between Medicaid payments and staffing across ownership types.
That's great. And Eddie and team, just a quick time check. It's about 4:45 here, 4:43. So if we want to leave at least 5 minutes or so at the end, just flagging that for you. So Liz, take it away.
Yeah, Liz, feel free to streamline as appropriate.
There we go. Sorry, I was I was muted again. All right, so yes, I'll take us through the last study as quickly as I can. Can you skip forward, I think, 2 slides? Because we kind of already went through actually one more slide. So we are using the same data for this. Like the prior studies, this one used the data on the per diem Medicaid rates plus nursing staff levels from the payroll-based journal and the facility and resident characteristics from the sources mentioned earlier. Next slide. The sample was constructed in the same way as our original payment to cost study, except with the additional exclusion criteria related to facilities not reporting staffing days, using the payroll-based journal data for all dates in the cost report period, and not having MDS long stay assessments. So our final sample was 9,510 nursing homes in 44 states. Next slide. And for this analysis, we only used the facility level statutory Medicaid payment rate for the explanatory variable. We couldn't use the payment to cost ratio because staffing is such a significant cost to nursing homes. So using this variable would open us to the endogeneity issue that Eddie explained earlier. And it was, again, we categorized this variable into 7 groups. Next slide, please. As noted, nursing staff levels for the dependent variables is nursing staff levels. As noted, the nursing staff levels were calculated from the payroll-based journal data and were measured in hours per resident day. Separate nursing staff levels were calculated for RNs, LPNs, nurse aides, and total nursing staff. So most prior studies use staffing levels obtained from cost reports or annual recertification surveys, and the payroll-based journal data is more precise. For ownership, we had 3 ownership types derived from the Medicare cost reports: for-profit, not-for-profit, and government. As far as we know, this is the first study to look at this association between Medicaid payment and staffing by ownership type. Next slide, please. And then these are the same resident and facility characteristics that we accounted for in the regression analyses that Eddie mentioned earlier. Next slide, please. And we also performed similar analyses. We did descriptive analyses, then bivariate analyses, followed by linear regression, and then a subgroup analysis by ownership. Let's move right into the findings. So as Eddie mentioned earlier, most nursing homes, almost 80%, had average Medicaid payment rates under $225 per day. Next slide. Nearly 3/4 of our sample were for-profit facilities, almost 20% were not-for-profit, and the remainder were government-owned. Next slide. Nursing staff levels for all facilities averaged, this is in the left-hand column, 0.58, 0.87, and 2.26 hours per resident day for RNs, LPNs, and nurse aides, respectively. Total nursing staff hours per resident day was 3.7. The highlighted numbers here are the highest hours per resident day for each type of nursing staff. Not-for-profit nursing homes exhibited the highest total nursing staff levels at 4.03 hours per resident day. Average RN and nurse aide hours per resident day were also highest in not-for-profits at 0.73 and 2.49, respectively. LPN hours per resident day were highest in government nursing homes at 0.9. Next slide. Our unadjusted results indicate that staffing levels increased progressively as Medicaid payment rates increased for RNs, nurse aides, and total nursing staff, but not for LPNs. What's highlighted here are the highest staffing levels by payment level. We see average nurse aide, RN, and total nurse staffing hours per resident day rose from 2.14, 0.46, and 3.43 at Medicaid payment rates of 0 to 175 per day, respectively. This is in the top row, to 2.63, 0.81, and 4.19 hours per resident day at more than 300 per day. Conversely, average LPN hours per resident day were lowest at the highest Medicaid payment rates at 0.79 and 0.76 versus 0.84 or higher for the 5 lowest Medicaid payment rate categories. Next slide. Similarly, the regression results indicate that with the exception of LPNs, higher Medicaid payment rates were associated with an increase in staffing levels for nurse aides, RNs, and total nursing staff. For example, relative to the lowest Medicaid payment rate category, nursing homes with the highest Medicaid payment rates at greater than 300 per day had higher nurse aide, RN, and total nursing staff levels at 0.31, 0.25, and 0.52 hours per day, respectively, highlighted at the bottom. For LPNs, though, compared to the lowest Medicaid payment rate, moderately higher rates of 176 to 250 were associated with higher LPN staffing levels, but there was no statistically significant difference after rates were higher than $250 per day. Next slide. Turning now to ownership, we see that average total nursing hours increased progressively from the lowest to highest payment levels, independent of ownership. The highlighted numbers are the highest staffing level for each payment rate category. For-profit nursing homes exhibited the lowest average total staffing hours at each level of payment. Not-for-profit facilities exhibited the highest average total staffing hours per resident day at most payment levels, with a few exceptions for government nursing homes. Next slide, please. And the regression results confirm that regardless of ownership type, total nursing staff levels increase as Medicaid payment rates increase. Generally, not-for-profit and government nursing homes seem to be more responsive to Medicaid payment rate increases than for-profit nursing homes. For example, increasing Medicaid payment rates from the 0 to 175 category to the 251 to 275 category, that's the one highlighted, was associated with around 0.58 hours per resident day increases in total nursing staff levels for both not-for-profit and government nursing homes, but only a 0.35 increase among for-profits. And this pattern existed for all payment categories except the second lowest, or 176 to 200. Next, two slides ahead, please. So to summarize the overall findings, this study provides evidence at the national level that Medicaid payment rates are strongly associated with nursing home staffing levels, underscoring the key role that state Medicaid payment policies play and influence the quality of care. Across all nursing homes, higher Medicaid payment rates were consistently associated with higher staffing levels for RNs, nurse aides, and total nursing staff. Moreover, these associations were consistent among for-profit, not-for-profit, and government-owned nursing homes, though their responsiveness to higher payment rates varied. In contrast, higher Medicaid payment was not consistently associated with LPN staffing levels, both overall and by ownership type. Next slide, please. And of particular interest is that higher payments bolstered staffing levels for nurse aides and registered nurses. These are the two types of nursing staff that were the focus of CMS's attempt to implement the federal staffing minimum standard in 2024. And the result for RNs is notable given the evidence linking RN staffing to quality outcomes. The limited association between Medicaid payment and LPN staffing, which we see only up to $250 per day, suggests that at higher Medicaid payment levels, nursing homes are turning to RNs over LPNs when they increase their licensed nursing staff levels. Next slide, please. And finally, consistent with previous work, the study found that not-for-profit nursing homes staff at higher levels than for-profit nursing homes. Importantly, though, our results found that all nursing homes, including for-profits, staffed at higher levels in response to increases in Medicaid payment rates. This is an especially important finding given for-profit nursing homes' disproportionate reliance on Medicaid as a revenue source. Still, there were notable differences, with for-profits responding less strongly than not-for-profits to payment increases at the highest payment levels, greater than $250 per day. It may be that at a certain level, not-for-profits continue to invest in nursing staff, while for-profit nursing homes invest these in additional funds in other areas. Alternatively, higher payment rates might be associated with greater profits, which for-profits return to owners, an option that is not available to not-for-profits. And I think perhaps we can skip over the study limitations, which is the next slide. It's very, very similar to the previous study, and then the implications are also something we can discuss, I think, with our last few minutes.
Hey, fantastic. Thank you all so much. That was a very extensive presentation with lots of great information. And I know it's going to take all of us, it'll take me, I'll just speak for myself, a while to digest all of it. But Emily, maybe we can take down the slides so we can just all see each other a little bit more. And again, I think, folks have been chatting in, and Mark and others have been responding to a lot of the questions in there. There's a question from Louise Locke. She said, were the cost reports analyzed to see if there were payments being diverted to owner affiliates, like self-dealing versus true costs, mortgage, inflated rents, management fees? I know that's something that has come up. I don't know who from the team might want to address that, but Emily, maybe we can just take down the slides.
Yeah, so I mean, what we wound up looking at when we're looking at, so for Medicaid payment rates, we don't look at that at all because we're looking at what the statutory rate is. When we're looking at these payment to cost ratios or the estimated Medicaid costs, we did an analysis where we look at something that's called with and without related parties. So the related party is where, for example, you might have the same owner of the nursing home maybe rents out the building and it also owns the building as a separate entity. And what we found is that those estimated costs, if you look at those using those types of related party transactions or not, we're generally in line with each other. So while there might be some bad apples out there, it seems to be that most of them are charging things that are in line with what the industry standards are.
All right. Thank you, Mark. Do you want to add to that or say something else?
Just real quickly, yes. I just want to emphasize that, we're looking across averages. So as I want to re-emphasize the point that John just made, which is that that phenomenon can exist, the self-dealing that you referred to, but apparently, at least based on the data, it is not enough to influence the averages on an industry-wide basis.
Okay, great. And Liz just chatted in the link to the full report for anybody who wants to look a little bit more into that. again, Melody said, is there somewhere a quick guide that can even exist to give a synopsis of rates and how they're set? So one of the things that I think is really interesting about this particular topic and the wonderful group of people who are on this call, which is a very diverse group, is, there's some of us that professionally we've done a lot of work with rate setting or understanding, government systems across different states for that. And others, it's if you're not in it, doing this work professionally, it's, for me, before I did it, it was just a black box. I didn't understand it at all. So I think I'm seeing in the chat, from Melody and others kind of, is there a quick reference or a basic reference? And, for the folks who are at the university and you guys are doing a lot of this, what do you think, Eddie?
So, Map Packet, has a sort of a nice policy brief, just outlining generally how rate setting occurs. They did a study back in 2019, but rate setting is complicated because if you go into the details, it's just, unless you're in the industry or you're in government, it's very hard to sort of discern, what's going on. But I really urge, and I have urged advocates to look at rate setting as a potential avenue to pursue quality improvement, oversight, and accountability. And so back in 2011 or so, I and Cynthia Rutter from New York State, we did a project where we looked at Minnesota and New York State, where the advocates had been active in influencing rate setting policy, and just and had some really nice outcomes that come out of that. And so we put together sort of a primer for consumers and to encourage them to get active and look beyond sort of the inspection process and other and mandates to include that, but if they would wish, but to use payment as a way to incentivize desired behaviors on the part of
yeah, and I would just go one step further. It's important to understand, like Eddie's right, there is a MacPac report that was done about 2 years ago that talks about the general rate setting policy. There's a nice Excel file that sort of says here's the components. The problem with it that most people don't know is a lot of states that did acuity-based Medicaid rate setting did it based off of RUG scores. And RUG scores were in the MDS assessments until October of last year. And so now in that section Z of the MDS, we're now using the PDPM HIPS codes instead. And so because of that, a lot of states have now changed that. And I think it's important for people to look at that, but understand there's a lot of changes going on right now. And now's the time to sort of be engaged in that. And it's another thing to think about is some states like Ohio, the rate setting is determined by the legislature, but other ones it's determining by the Department of Health. Right. So like in California, it's entirely driven by the Department of Health. And so who you talk to may be different in each state as well.
Yeah. No, that's really helpful. And I know we only have 2 minutes left, but I wanted to just draw people's attention to Marc's response about the policy implications question, which is, of course, a great question. And, Marc said what you pay makes a difference and that it's important and has implications for staffing and quality of care. And I think what this work is trying to do is, again, look at a big set of data and say, what is this telling us? And how can we learn from and apply it? I just before we wrap, I do because we have Dr. Jane Carmody on the call, and she's so good to join these calls. If we can ask you to unmute yourself, Jane, and just invite you for any thoughts that you'd like to contribute here. And Emily, if we can unmute Jane.
There you go.
There you go.
There we go. Thank you. Thank you. Oh, well, we've been looking forward to this, Alice, and we're so excited that you had this conversation. And I just find this information just fascinating. And like you, Alice, I want to better understand what it really means and what we're saying. We work, thank you, Alice, for the work you do, but we also work with NASHB on more of a state focus, and I really want to kind of engage in a conversation with them as well. Not they don't do nursing homes for us, but they do palliative care and family caregiving. So it was fascinating, Alice. How lucky are we to have this information and to better understand and relate to quality and relates to star ratings. And I think people put it in the chat about, the patient experience, the resident experience, the family experience is certainly something to add to this. But thank you so much, Alice. Thank you for
All right,
having us.
great. Well, thank you, Jane, for those comments. And again, it's 5 o'clock Eastern time here, so we will wrap up. But many thanks to Emily and Jennifer for running interference, and glad we were all able to get back on this call. Really, really grateful to all of our speakers today. Thank you. You may get some follow-up questions from this terrific audience, and you really got us thinking. So we're grateful for all of that. Jennifer, Emily, anything else to add before we wrap? No, I'm seeing them shaking their heads no. So again, thank you all so much. Have a wonderful rest of your week, and we hope to see you on another coalition call very soon. And thanks for supporting the Moving Forward Coalition. So thank you all very
so much. Yeah. Love to hear more. Yeah.
Bye-bye.
I love the comment from the West Coast. Lunchtime is over. Now back to work.
I'm ready for bed. It's my bedtime now. Thanks, Mark, Eddie, John, and Liz. Thank you all so much. It's great.
Thank you.
Yeah.
Thank you.